Thank you. There's so much energy in the room. I'm also inspired. I'm with you. You guys have some so nice voices. I think you should try being musicians too. It's not too late yet. So the next speaker, the next session is more of a panel session, and I have the opportunity to introduce the moderator. He's a primary care physician. Most of us know him for his contributions as a respondent on Minnesota Public Radio. Ladies and gentlemen, let's welcome John Halberg.
Good morning, everyone. It is such an honor to be here, and we all said as we walked out here giving Joya a hug, holy cow, is that a hard act to follow? And I tend to be a very modest person, and I don't brag about too many things, but I have to tell you the one thing I brag about unabashedly, unapologetically, is that Joya and I started med school together, and we met on the very first day, and truly, she's one of those shining lights in this world that I am very proud to call a friend. And it gives me such great pleasure to be here with you today. I don't know if I've ever been to a conference where there have been so many luminaries, and I have a feeling that everyone in this audience feels like you are changing the world just a little bit. And I suspect that some careers are changing based on what's being said here and experienced during this conference. So thank you so much for giving me the opportunity to moderate this session. As you can see, it's called Global Perspectives on Social Medicine, a conversation on the gritty realities of teaching social medicine. And I'm going to introduce our 5 panelists. And as I say your name, if you could just raise your hand so we can put a name with a face. So Dr. Pierre Paul from PIH in Haiti and Malawi. And then we've got Sande Ojara, SOCMED, and St. Mary's Lacor Hospital in Uganda. And then we've got George Thibault from the Josiah Macy Junior Foundation in New York, Dr. Grace Akello from Makerere University in Uganda, and then Dr. Amy Finnegan from right here in the Twin Cities. And so what we're going to do is we've got 3 sort of prepared sections that we'll go through first. And then once we've done that, it would be a crying shame not to give you an opportunity to ask questions of this esteemed panel. So we're going to be handing out question cards at some point. And when you see those, if you have a question that pertain to these conversations, feel free to ask that. And if it maybe pertains to something you've heard before, that's fine as well. And I'll go through those and try and put some questions together at the end. So we'll have a conversation at the end with our panelists. So to start, what we thought would be interesting to do is each of our panelists have chosen an image that represents what social medicine means to them or how it affects them. And so we're going to go in alphabetical order, and we're going to project the image that they have chosen, and they're going to talk a little bit about it. And then we'll get into the 2 prepared questions after that. So we'll go ahead and start. We will need an image projected. There we go.
This is my image. Out of the very many, I had a difficult time choosing which image to present. As a medical anthropologist, I have the privilege to move from the clinic and to the community and back to the clinic. So this image speaks volumes to me. During my anthropological study, I assessed healthcare complaints with the communities in northern Uganda. One of the diseases which was dreaded was epilepsy. And it was highly stigmatized. It was a disease which could make people evict you from one community, and even the next community, they would tell them this person is dangerous, and they would evict you from there. And for school children, having a seizure at school was enough for the parents to tell the head teacher, please dismiss this child from this school because he is dangerous to our children, he is dangerous to others, simply because they believed coming into contact with the body fluids of the person make someone have epilepsy. And in one of the schools I was, when a child had a seizure, all the children ran. All the children left that point. Teachers too left that class. And as I struggled with the child and trying to give first aid, others now came to look through the windows. What is going on? Is Grace going to have a seizure next time? Is Grace also going to have epilepsy? And this affected our way of working for so many months, until I went back to the psychiatric clinic and told them about this. It is important that you're giving the people medicines free of charge, and you're advising them to come for refills every month. And some of them are courageous enough to come for these medicines. But there are those in the communities who don't even want to talk about having had a seizure. When a child, for instance, has a seizure, it's better they send this child from where the parents are staying and telling the child to go deep in the villages. For instance, within the Gulu municipality, it was difficult to find children living with epilepsy, but when you go to villages 10 or 20 kilometers from the municipalities, you find more children, because parents in the municipality are very afraid of having these children, because it will affect their way of working. It will affect the idea that even landlord will give them an apartment. So the main message for us as a team from the clinic is to do a role play in the different schools and tell them the only message we came with today is to tell you that epilepsy is not contagious. And please, the best way you can respond to a person who has a seizure is give them first aid. Remove the sharp objects around there. Remove any dangerous or wooden pieces around. Try to make the person comfortable. And we can confirm to you that you will not get the disease. It was a very powerful way of reaching out the communities. And with the schools which participated, during that session when other children would demonstrate that you can help a person living with epilepsy, other children would cry. They would want to move closer. For the first time, I would see children want to move closer to see how is it possible that actually you can help a child living with epilepsy and you don't get this disease. And it was part of a research project sponsored by the American Academy of Pediatrics. What happened is, over the 3 years, we saw children attending primary schools within the municipality, simply because the parents had come to terms with the idea that, yes, we've seen it with our own eyes. We've been told by professionals that you can assist a person with a seizure, you can offer first aid, you can counsel them, and you'll not catch the disease, you'll not be affected by this ailment. And as one of the most important outcomes we documented in the psychiatric clinic, many people were not afraid anymore to come for diagnosis or for refills. Many people, up to 400 over 3 years, came to be assessed as to whether the seizure they had was because of epilepsy. And for this, I am very grateful for my discipline that the ability to go to the community, or the demand as for anthropologists to go and listen to the people, to go and discuss with them their health complaints, and to assess with them, prioritize with them what is important at that particular time, puts me, I think, at an advantage to what a clinician does. Because in my caption I said, clinicians are doing a great job. They are making sure that anti-epileptic drugs are delivered in the clinics. They're making sure that they are there on time for the people who have come for refills. And these other broader issues which affect their patients also need to be addressed. And for me, I was lucky that they were willing to come to the communities. They were willing to come and share their experience. They were willing to come and partner with us. I like the term which was mentioned this morning, paradigm merge. Previously, as an educator, I was a bit uncomfortable with having people who, teaching students. I teach different levels. I teach master students, undergraduates. I teach also doctoral classes. I would feel very uncomfortable imparting knowledge, and later on, when I see the behavior of the person, it seems like they didn't grasp anything. Yeah, and with time, I have this idea. It is possible to impart knowledge, but it's also impossible to engage in transformative education, where the educator sees in the student the ability to transform the theory into practice, the ability to appreciate that the patient can have the presenting complaint, can have the disease, can have, for instance, in a mental health department, can have the depression. And it is okay to treat these symptoms. Sande is one of my students whom I'm very proud of, as a student who is able a student whom I'm confident to talk about as a person who is engaged in transformative education or transformative learning. That some of the things you don't easily just brush off. You go ahead, you go a little further and ask, why is it so? Why is it important for me to go beyond the biological disease? Why is it important for me to focus beyond on what is happening only on the physical body? Why, for instance, is a client coming more times to the clinic compared to others? Why is it that more children from a certain suburb come to the diarrheal disease unit for treatment and for admission, while other suburbs, you never record any case? These are the questions I try to engage with and try to tell the medical students about. Previously, I would have this impression, yes, I am trying to stretch them too far. I'm trying to help them think differently. I had the paradigm shift in mind, yeah? But with time, I'm trying to do paradigm merge. Paradigm merge, I go back with this. I want to appreciate what is happening in the clinic. I want to appreciate what the health practitioners are doing to restore normality. But I want also, as an anthropologist, to bring to the clinic what I see out there, what I see, what stories I am told in the communities, what I have participated in, what I've seen a mother do when they have a child with a convulsion. I want these ideas to be merged in one person, especially in healthcare providers. And even better, if they can agree with me to move from the clinic and see for themselves. This I found very powerful, to move from the clinic 2 hours a week and go and see for themselves what is happening in the communities, what narratives are there. Because what I've also seen is that because of the differences in power relations in the clinics, the patients also adapt. They think of certain narratives which the doctor might easily accept. And also during the clerking, there is a way that even the questions asked are only leading towards finding out what is happening to the body, such that if a mother has or is overwhelmed with things happening at home, there is limited room to now bring them up. The symptoms will be described in depth, but later on when you talk to the same mother in the clinic, they are confident enough to tell you, but how would I already start telling them about what these are the issues in the village. These are the soft issues which are affecting my health. These are the factors like lack of food, lack of clothing, the idea that I can't buy a mosquito net for the child, These they are partly eliminated during the clerking, because somehow also the medical system that we have trains the student to logically arrive at what is happening to the body. Yes.
Thank you,
Thank
Dr.
you.
Akello.
Thank you.
So we're going to go from an anthropologist to a sociologist, Dr. Amy Finnegan. Thank you.
Hello, everyone. It's great to be here. So my image is taken this January in Amuru, Uganda, which is about an hour further west from Gulu, which is where we teach a SocMed course there. And this is in the midst, I believe, it's not after, it's in the midst of a soccer game with our students, our social medicine students coming from St. Thomas and the University of St. Catherine's, from universities Makerere, Gulu University, and Mbarara in Uganda, a student from Zimbabwe, and a student from the University of Rwanda in Kigali. And we are playing a soccer match against the community health workers and the staff at the Muru Health Center Level 3. And this, to me, is about relationships. This is what I'm trying to capture and highlight here. So I really liked that image of the stone soup, and we all bring something different, and Joya brings carrots, and I bring beans as a sociologist. I'm interested in how we act upon the social determinants of health, which I believe requires structural change. And I think to do structural change, we need partnerships. And to do partnerships, we need relationships. And that is the key for me and what social medicine is about, and why I'm drawn to it, is trying to create meaningful relationships. And in particular, meaningful relationships across difference, across where we all come from, across race, class, sexual orientation, geographic origin. And that's what we try to do in our class, and that's what I try to do in all my classes, is to try to create a space where people can come together and dialogue with one another and become friends. And real friends, like authentic relationships where we're vulnerable with one another, and we share what's hard, and we share what's joyful, and we dance together, and we eat together, and we try to think about these really big problems in the world together. And so for me, social medicine is about relationships, and that is what I think captures in this picture. And by the way, we won this soccer game. It was the first year we ever won, so we're pretty psyched.
Thank you so much. So Dr. Ojara.
Thanks. I think probably there's another image that should have been projected together. But I want to thank this gathering to reflect and understand why has the world remained what it is, despite of all the advancement. This was the stemming point when I was a young student, and I asked my professor, why are you a professor? So many problems remain intact. Where is the confusion? And then I fall back. I wish they could project for me the image with the root of the tree. In the powerful image that I expected, can I have the better image? Okay. In the power of the image that I expected in the root of the tree was how complicated issues within the social determinant of health have been driven by different forces in our society. And I ask myself as a primary care physician, how do we handle this? Where do we enter from? And I realized that within the system of our society, there is a lack, and that is the partnership. When you look at the roots of the tree, it is very complicated that you don't know which one followed which one. It's a pattern. I try to describe in the picture that has not been projected. It's a pattern that if you try to follow and see which one led to the end, you cannot reach to the point. And that is how complicated our society is. But who created this in our society? Who created this is the seed. And which is the seed? The seed is the system of the society which we are living in. And who takes the lead in this system of the society? I'm asking this question because it is affecting how we, the physicians, are practicing. And we are now meeting the task. We are actually carrying the cross of the burden of the society from the inequality and the injustice. My simple concern is, how do we flex back? In the hospital where I work, the issue is not about giving to someone. The issue is, can you find why someone is barefooted? In that picture, if you see, why is the young lady barefooted? You should fall back and ask the reason. It's not about to go down and give. When I first met with Mike in the year 2000, Mike was a resident student who came to do his task in the hospital. And he projected a community problem that I perceived that it was real and passionate. And when I approached him and we started to collaborate with him, I realized there was a power in how to handle this at the community-based ground. And this promoted me to grow and understand what is the need to address the real community problem. And through education, it was possible to talk to some of these issues. So I find that there must be a stem root of a system within the community that addresses a problem of the community by the community. And which one is that? It's the power. And what is the power? It's the education. And where does it come from? From the policymaker. And that is how complicated the system of the community is, like the root. Take it from my thinking that we have integrated root system in the community that need to be unlocked by you and me. And this is the picture. It's not only about giving the sando to someone, but it's about empowering someone to ask and make the sando for himself. And this is the dedication. If we can make our people understand, then the poverty that we are talking of, perfect. I am now happy for my picture.
You did a great job describing it.
The issues is bottleneck causing us the challenges. So there are a lot of issues that are very complicated. And this is the reality I've described to you. So the stem on that foot you're seeing, who has the power to decide in our society? And how do they get the power? We need to educate an individual who will become the seat of power in the community. And the seat of power in the community will now decide how to unlock this. You can see the patient lying down there that is in the compound of my hospital, St. Mary's Lacor Hospital. I ask myself, how do I battle with this game day by day? And this has been very powerful when we interact with the student. One thing that I appreciated, like my teacher here, Grace Akello, has mentioned, I love so much the medical anthropology classes that was taught. I found it very interactive because it was not a discipline of medicine. It was not about the germ theory, but it was about the culture where I grew in. So I took that a very serious note that this is a very important topic. And then I interacted it to my environment. I grew up from the northern part of the country, which went through the 20 years period of war. I've seen all the life sort. So I integrated what she taught and what is the medicine and where is the problem. And I acted to say, I must do the medicine that I think I'm serving the people. And that's why we find a lot in SOSMED when we get students from the state, students from Rwanda, and students from Uganda joining in dialogue in how to share their different experience to answer questions. I find that it's a living tool that we probably can find a way to unlock the root of the tree I've projected over. For the moment, thank you.
Thank you so much. Dr. Paul.
Thank you. And this is the right picture. So I took this picture in 2005, and at that time I was working in Ange in rural Haiti. I'm from Haiti. And that picture, I took it somewhere between Tomod and Ange for those of you who've been working in Haiti. At that time, I was working very closely with Dr. Evan Lyon, who is sitting here, and with the whole team, Paul, former Polo, Joya, Ferne, Macy. That was the first time. So just quickly, in Haiti, when you do medicine school in the public sector, you spend the 6th year of medicine school in a rural area doing what they call the social service. And for most of us who have been doing medicine in Haiti, we have all come from Port-au-Prince, the capital of Haiti. And it was the first time that I understand what the reality of living in rural area was. And I remember I had a patient, and the reason I took that picture is there was a patient one day who came with the complaints that they had an accident, they had a car accident, and there was a bag of rice that fell on them. And for me, with the years I've spent with Partners in Health working in Haiti and Malawi, I've realized that there is a proximity if you don't have it with the issues of the patient, and it will be very difficult to understand what they are saying, their complaints. And for me, this picture, which kind of showed the way people, folks were living in Haiti, were traveling. And when you see that picture and you imagine an accident happened, or this car had to brake suddenly, and then somebody fell from the car by inertia, and then there was a bag of rice, because there was a couple of bags here that are not attached to anything that fell under that person. So it's very hard for that patient to explain all that process. They will just come and say, I had an accident, and I have this kind of pain, and you will have a hard time to make sense of that pain, and you will basically teach them that this is not the right kind of pain you're supposed to have if you have an accident. So maybe I can help you reformulate your pain, because that's not right. That's not the way I've learned about the kind of pain you should have had. So I think having that proximity with the cause of the patients and the way they live, the way they sleep, the way they have their normal life. And there was a previous speaker was talking about the given that need to become intolerable. I think they are given now, and we need to know them. And I think when I'm sharing with colleagues about social medicine, I always think that proximity to a patient and the issues are really the best way to learn and to be able to be useful to them.
Thank you so much, Dr. Paul. And finally, Dr. Thibault.
So it's a privilege to be here, and I'm just overwhelmed with the size and enthusiasm of the audience. This is a picture of me and my father, and I learned social medicine growing up in a rural town in upstate New York, a town of 2,500 people. My father was the general practitioner, the only doctor in town. Office was in our house, no answering service, phone rang 24/7, so I knew when everybody in town was sick. I knew when the babies were being delivered. My father took care of everybody in town. He was more than the doctor. He was the public health official, the school doctor, and in some ways, the minister to the people of the town. So that was the medicine that I grew up with. People were charged what they could pay. Many paid on a barter system. We had produce delivered to the back porch or had the house painted. People worked off their bills and gave services in return. This is the 1940s and 1950s in central New York in the United States of America. And the social mission wasn't really talked about. It was what was lived. My father lived that experience, and I vicariously lived it through him. Sadly, he died prematurely at the age of 49 before I entered medical school, so I never got to talk to him about what social medicine meant to him he might have been puzzled and perplexed by that phrase. It was what you needed to do to take care of people. And taking care of people meant being part of their community. It meant being available to them 24/7. It meant not caring whether they could pay or not for their services. And it meant understanding all the things that went into their lives. So he was involved. I knew enough as a teenager to understand there were issues of domestic violence, there were issues of substance abuse, there were issues of teenage pregnancies, all in this little town, all funneled through his office. So I tried to carry those messages with me, and before we talked about social medicine and the social determinants of health, we just talked about being part of a community and what it meant to serve a community, and medicine as a calling, medicine as a service, and that every aspect of medicine is in fact social. And that's the lesson I learned growing up with my father.
Thank you so much. So I have a question for the panel, and I think getting at kind of this gritty reality of teaching. First of all, we can't escape the fact that you represent such an interesting range of countries. We've got Haiti, Uganda, Malawi, the United States. Within the United States, we've got Minnesota, Massachusetts before, New York. So with that in mind, I'd like you to ask, the question I'd like to pose is, can you highlight how teaching social medicine differs from your perspective and where you are from perhaps, other places? And I think really speaking from where you're at. And I'll let any of you take a stab at that if you'd like to start with that.
Well, I'll go first, because I have a slightly different perspective than the others. I'm now viewing it from the standpoint of running a national foundation in the United States, where our focus is totally within the United States. Having previously been a teacher of medicine, and happily some of the people in the audience I've had the pleasure of working with over the years, in the years that I was at Harvard-affiliated hospitals. But when I came to the Macy Foundation 8.5 years ago to run the foundation, my idea and the reason that I left my wonderful position at Harvard to run is that I had this sense that we could do better. As good as things were, and I worked with wonderful colleagues, and the missing piece, I thought, with, and I'm not just talking about the education of doctors, the education of health professionals in this country, is that it had become misaligned. We needed to align the education more with the needs of the public. We needed to be less inward-looking, satisfied that we were meeting our own standards, which I would confess as an educator was what I had been mostly obsessed about during my years of running educational programs. But not ask the question whether we're meeting our standards, but whether we were meeting the public need. And that education needed to be aligned with the public need, not with the internal needs of either the profession or of the organization in which the education occurred. That was that misalignment was what I sensed, and what took me to my new mission in life, which was the Macy Foundation, and aligning health professions education with the needs of the public in this country. And there were a number of ways we've sought to do that. First of all, it's very clear that the experience that learners have matter. And if all their experiences are in one kind of setting and one kind of place, they're not going to know about the rest of the world. They're not going to know what the possibilities are, and they're certainly not likely to do it. So changing the nature of the clinical experiences to put them more in the community, and whether that community is in Roxbury, Massachusetts, or whether it's in Haiti, to me is almost immaterial. It's the nature of the community experience, and that it be longitudinal, it be immersive, so that relations can form, and so that the learner and later practitioner becomes a part of the community and a part of the team. The second is that they need the content and skills. There is a learning part of this, to knowing what it is you're looking at. So learning about the social determinants of health, learning about population health, learning about how health systems work, how health economics work, is an important additional thing. Third, they need to learn to work in teams. All of our health professions education, at least in the United States, has been absolutely siloed. Intentionally, the professions are kept apart until they're completed products, and lo and behold, we're amazed that they don't work together. So we've been breaking down those barriers. No single profession can meet the patient's needs, and no single profession will certainly solve the social problems that underlie poor health around the world. So we need to teach teamwork, we need to teach respect for the other professions, and we need to have learners learn together so that they're practicing those skills from the beginning. And then we need to develop the faculty. All of this that we're talking about is not the way our faculty learned. We can't expect the faculty to teach in ways and in subject matter that they hadn't been taught themselves. We've paid too little attention to the need to bring the faculty along. We're often critical of them. Oh, the faculty doesn't get it. Well, what did we do to help them get it? So we put a lot of effort in developing faculty for this new orientation. And finally, we need a more diverse health professional workforce, not only so it can match the public it serves, so that is the point that's already made, the learners can learn from each other by sharing experiences. So we've been on this mission to align health professions education in the United States with the needs of the public. I regard all of that as social medicine, whatever we call it. I think all of health professions education has a social mission because the purpose of health professions education is to improve the health of the public. I'll stop there.
Thank you. Another panelist?
In Uganda, what I've seen is a shift in what was the traditional way of training medical practitioners to a new approach, whereby there is an emphasis on interdisciplinarity. Interdisciplinarity in that different people from different backgrounds work together to train the medical students. For instance, in the mental health department that I belong to, we have psychiatrists working together with anthropologists and psychologists. In other departments, it might be a little different, but the need and the will is there. The idea that they recognize that they can be helpless with only focusing on the body. And for instance, in the pediatrics unit, the idea that you can treat children with diarrheal diseases throughout the year, and they're not new cases. Most of them are repeat cases. You are likely to see the same mothers coming back and not new mothers. This has made them think, what else can we do? How can we make our practice better? How can we equip the students to recognize that even when you're clerking, the idea that a particular village appears more frequently as somebody's home, like where the person stays, is important, and not just one of the things that you want to, one of the records that you want to take. How can we help the student reflect on the nitty-gritties, the small bits that, the small pieces of information that the patient is giving? So I think in my country, the emphasis on interdisciplinarity in training the medical students is very important. The other issue is immersion learning. Students are required to go to the communities to see for themselves. There are those who have grown up in the cities and they have no clue about what is happening in the rural or in the village settings. So as a requirement within the curriculum, all students are supposed to go to the communities to live with the different with the different cultures, and this has enabled them to have like a more comprehensive outlook and a more comprehensive interaction with the clients that come to the clinic. Thank you.
Thank you. Dr. Finnegan, do you want?
So the last couple days when we had this social medicine educators workshop, one of the things we talked about was defining social medicine as both a noun and a verb. And so the noun being the empirical reality of the world and how unequal the world is. And the verb being the actions that are required to undo that inequality and to address that inequality. And so I'm going to speak from a sociological approach, which I try to apply in classes here in the United States, in Minnesota, and previously in Boston, but also in Uganda. And that is an approach to teaching that tries to highlight power and privilege and the variations of power and privilege in the classroom and in society. So I think our contribution as sociologists and social scientists to this practice of social medicine is to really focus on the verb and the practice of building power to undo some of those structures that are perpetuating inequity. And that's a hard thing to do, especially for health professionals who are being streamed to work primarily in clinics and to see patients, which is a very important and necessary job. But that work alone is not going to undo all these structures that we've identified as so problematic to why they got there in the first place. So I think one of the things that I and others are trying to do in sociological approach is to teach students about building power through social movements and through advocacy. And we do a bit of this in my classes, and part of it's just by learning about the incredible work of social movements like the Treatment Action Campaign in South Africa, ACT UP here in the United States, the ongoing work around access to essential medicines. But then those are all healthcare related, but then there's all these other broader social movements for racial equity, for example, Black Lives Matter and others that are very much ongoing that I think are major, major contributions to social medicine because they're essentially trying to address inequity. And so I think what I would like to do, or what's sort of an approach that I think is important in my practice of social medicine, is helping students be aware of those movements, have an appreciation for them, and also eventually contribute to them. Because these movements are not, we need lots of people. We need lots of people working for equity. And I think it's integral to the verb dimension of social medicine. So that's my focus and my interest.
Thank you. Dr. Paul.
Maybe quickly, I think we emphasize a lot on the things we are teaching when we are sharing with our experience with classes, with students about social medicine. But there is also the other aspect of it, the things that basically social medicine force us to make people unlearn. Because there is a learning that happens. There is a lot of things, there is a lot of assumption that a physician have, and some of them you need to unlearn them, depending on your culture, in order to practice real social medicine. I think communication is one of them. In general, and I was raised in that context where really you will use a lot of words that you know the other people don't understand, but you use them anyway because that will translate that you have a certain status and you know what you're doing. And I think unlearning this kind of approach help people get access and help you to connect with people. And I think when you see various culture, there are things that you could see, like in the medicine school, and I had the chance to have been in different contexts where the teaching of medicine itself, the kind of classic medicine, was different. So you will see in a place like Haiti, for example, the engagement, the social engagement of students, it's very strong, and I think we can actually tone that a little bit down. But in sort of other place, there is a real need for students to be engaged. So I think there is a lot of difference. There is a lot of things to learn, but I think there is also a lot to unlearn from kind of classic education.
Thank you.
On this issue of how to teach social medicine, when I look at my country, Uganda, I want to give perspective in two forms. One as a trainee who has undergone through the training, and then also as someone who is trying to practice social medicine. When I review how I was trained, I think there's a lack in how to teach social medicine. There is no clearly spelled out, this is a social medicine domain or a discipline, how to approach it. And this is a lack that I've found during a session in the class where so much of the history of the community, the factors that affect the community are much spoken in a classroom base. And this leaves us only to think of the theory of the disease process. And when we come out in the community, we are more clinical based. And this is one perspective that I thought it needed to be addressed. And when I look at the cadre that are trained in the country generally, it's diverse. It's not only the graduate student, it's not only the postgraduate student. There are other there are different levels of the health professional training that varies. So I found that there's a lack in certain discipline. You have a school of medical laboratory, you have a school of physiotherapists. There are certain elements which are key in social medicine that need to cut across board. I find that lacking. Now, what did I learn during the training? The powerful thing that I learned as an individual, it was in the community outreach. I was able to get an element of narrative medicine in a community diagnosis, working with the community. I found this was a powerful tool that needed more mentorship on it. And because of human resource, sometimes this area is properly injured during the training because you may get to the community and you don't have directly your mentor, and the question that you are supposed to ask and give a results, you don't have a feedback, and probably you post up a research thinking that you need to intervene in, probably you lack the funding. So I find there is a gap in the education in the system. But what came to my mind, when I grew up to understand the broad problem of medicine, like I told you in the root of the tree, we met with Mike Westhouse, and this is the point when we stand up and thinking, can we think about how to merge ideas? And this is where the birth of SOSMED came in. Now we are able to integrate students from Uganda and students from the state to share different experience. And we are able to get to the community and try to understand deeply what is their problem. And we are able to get case-to-case discussion through a narrative case. And then we understand the patient beyond what they are. One challenge still left with us in this kind of teaching of the student is that we are yet not able to answer the community problem because of all the structural forces we've highlighted. So I find that it's very possible to teach social medicine by partnering with the different sectors in the community, because these are the powerful forces. When we get down to the community, we need to know those forces in the community that coexist. We need to know the community resource, like the finance, where they get their money, what kind of activity they're doing, how the culture has come about by it, so that we interact with them and we see how we can advance way forward. Now, this can only happen if you have mentors, you have people who are able to be with a student in the community. And this is the aspect of training that I think we thought we can advance it. And this is the concept of why social medicine is trying to exist. And then one thing, if you notice in the Focus 15, this was the power of our class already in the group, 2015. This was one of the classes that came up. Can we ask the president why we are not getting the 15% Abuja declaration that we must account for our health? So these are the kind of force of movement we are trying to do. In the country, if I would say, there's several different movements, but we are not connected. Social medicine needs partnership. We need to be connected. We need to have friends who have different experience. You saw through the histories, we started somewhere so well, and we reached somewhere, we lost the focus in social medicine. And this is the question I'm still asking. Is it easy to unlock the root of these trees? And this is the perspective I thought. Teaching of social medicine need, one, to design a framework of the curriculum, how all of us can share, both at the graduate level, at institutional level, different sectors, and we see how we can collaborate. I don't think it would be fair if only the the medical professional designed a curriculum without consultation with the community, without consultation with the anthropologists, without consultation with the sociologists. We need this integrated teaching. And I'm looking at social medicine as to be a universal training, okay? Not just to become a component of training right from childhood. You get to a school and they start telling you, wash your hand. Can we also tell the mind of the young growing one that there is need for equity and justice so that someone grow with it and we have a new breed of seeds of the next generation? This is my thinking about social medicine. It should be diverse in the training. It should be multi-sector in collaboration how to frame the curriculum, and it should cut across all the disciplines so that we can have a new human being, a new mankind that has a focus to answer some of these complicated reasons. To unlock that route, we need everyone to work together. I think this is how we are focusing in thinking about social medicine.
Thank you so much. So I'd like to thank the audience. We have some wonderful questions, and given that we have a limited amount of time, I'm going to cluster some of them, and I think we're going to start with one which seems very relevant to sort of the art of teaching this, and that is, how do we, as students coming into the medical field, inspire and incite others to continue and increase the fight for health for all when so many see it as a lost cause? And I read that question because it was a theme here, not just people going into healthcare, but how do we inspire people in communities? How do we inspire others, even within the medical field, not just primary care, but others? So I'll let you take that very broadly, but how do you have a strategy to inspire others to sort of take up the cause, take up the fight? Dr. Thibault, you grabbed the microphone. It looks like...
Well, first of all, I think that the students will lead and we will follow. And so I would give that message to the students, to the kind of optimism that I've heard here in this group yesterday and today, and the idealism and the preservation of idealism is so important. So I think that's important to acknowledge how much our learners in the next generation are going to be the powerful force to bring about change. To do that, though, I think those of us sitting in positions of leadership or authority need to empower them. I think in all of our educational institutions, and I can speak most from my experience in the United States, we underutilize the incredible resource we have in our students and in our residents. We get incredibly talented people that have been at the top of their class, have achieved great things, and then we kind of contain them and push them back, infantilize them almost, that they're not able to do this or that. So the students and residents need to push us, and then we need to make way for them to make them a meaningful part of the team as we look at not only the social change issues, but important delivery change issues, because delivery change is a piece of this as well. How the delivery system itself can be more responsive, more efficient, more equitable is an important part of that mission. And the students and the residents that we train often have the insights about how the system can be better, and also have the insights about how we can better interact with the community around us. We need to listen to them, we need to empower them, and we need to make them a meaningful part of the team.
Thank you so much. Dr. Akello?
Okay. I think we have not lost the cause yet. We are in fact reviving it. There is a dilemma as a teacher in the developing countries that I also grapple with. For instance, how to tell a medical student that it is possible to not end a consultation with a prescription for medicines. I always engage in a difficult debate with students, it is possible to give the patient words. It is possible to prescribe approaches which a patient can do. For instance, telling a patient that I can give you antidepressants for as long as you want, but you'll still be coming back for more. And at the same time telling them one of the reasons contributing to these symptoms is because you are actually immersed in a context where events. For instance, you've just lost a loved one. Making the patient aware of this, that having lost someone you were connected to may cause you to have sleepless nights. And perhaps not even prescribe for them quickly that for the next 3 months or so, you can have these symptoms for as long as possible until you are able to come to terms with this extreme event. Yeah? I think this is now a paradigm shift, that it is very easy to prescribe some of the medicines for symptomatic relief, but if you told the patient the truth, like your experiential knowledge, I think it will be more helpful for this patient to go through the process instead of trying to suppress it with other interventions. Okay.
Thank you. Dr. Finnegan.
I think in terms of inspiring students, I think two things come to mind. One is community building and creating spaces for people to build community, because working to address the social determinants, or as Joya put it, the social forces, we can't do that alone. We need to do that in groups and in collective. And I think creating spaces for people to build community that can kind of take a life of its own. Like, for example, that Focus 15 for Health video that we showed, whatever it was, an hour ago. I mean, that was the beauty and the magic of the friendships that were created a year and a half ago. And they were inspired. They were educated on the social forces, the social determinants of health, and they, had this understanding that advocacy played a role. But part of what carried that forward was the synergy of those people being together and wanting to continue to be together and see a project through. And so I think and that's very inspiring, at least it is for me in my own life. I think being around people that share similar values and ethics and are motivated for change. So I think community building. And then the other, I was going to say, in terms of inspiration that I think has worked for us has been, and we have work to do on this, to do more of it, but is the infusion of the arts in our pedagogy and in our teaching. In our classes, we use Theater of the Oppressed from Augusto Boal, who is inspired by Paulo Freire. And this is an experience where students are asked to use their bodies to shape concepts that we talk about in social medicine. Concepts like social justice, colonialism, agency, and to use your bodies to shape what that feels like and to really feel those concepts. And I think I think the arts, so theater, and another thing we've done is we've had Eric Gottesman, who's a collaborative artist, come this year and teach us about listening, and really, really deep listening. And students took recorders and went out into the community and into the hospital and into their conversations and recorded the sounds of the social forces, and then we played those back. And there's something so powerful about using the arts of recording and theater to learn concepts in a less linear way than we often do in social sciences and the biomedical field. And I think it pulls something on us beyond cognition. It pulls on sort of something more visceral, which I think can be very inspiring.
Thank you.
As a primary healthcare provider, I think we have a big mission to do. One is we are leaders, we are policymakers, we are educators. If we are able to interconnect and make partnership with other sectors, like in education, we are planting the seed in the young generation that will develop the mind of how to become a good physician, how to come out and be a good engineer. Now, if we've planted this seed by intercollaboration in education, The power to me is education. We are able to get the best product who will join the medical training. And that is adding into the pool of the next educators of the generation. So to me, it's the willpower of the mentor. Who are our mentor? If our mentor are not using the student properly to inspire them and give more seat in them, then we are not going to get the answer for the next generation. So I still find that it is very possible if we are able to train more people to come to join medicine by showing them what they deserve to do. And it is very interesting. I take this from my perspective of interactive medicine when we did a narrative case. You take a case clerkship of a patient and you go and review with the medical student. Someone appreciates what you've done, and you get back to the patient and you talk with the patient and you try to review where was the dynamic. Someone follow you back in the next day. It caught my eye just 2 months ago when I was working. Consultant is in another room. I am a primary caregiver in another room, but I'm having a number of students in my room. Then I asked the question, why are you not going to the consultant? The student told me, because you ask too many questions to understand beyond about the patient. So the way we mentor the student and the way we start this process will inspire more students. We need to get down to the community, give the equal opportunity for training. I was not trained a medical doctor. I wasn't the best graduate to join medical school. I first started like a nursing student, certificate. That's when I met with Mike, working in intensive care. I got inspired. I went and did paramedic. I got inspired. I went and did medical training. I've been in the medical training for the last 10 years plus. This is my own inspiration after seeing people doing it. So we need to give that model. What you're doing can inspire someone. I've been inspired by the way we treat people to recover from that problem. So to me, I feel that we are the challenge maker. We are the one to make the change. We are the educators. We are the policy makers. We need to interconnect, because if we are able to find out in the community that there's a gap in quality of admission of students to the university, how do we do it? At the global perspective, if the University of Boston has developed an idea that they feel that we need to share it with the University of Minnesota, can there be a forum that these two institutions form a synergy so that they build also a forum for the global network? The problem which is small in a particular region of the country or in the globe, tomorrow is going to spark up and become a global problem. So we need to share knowledge, we need to share tactic so that we inspire everyone. So I feel that there is a kind of lack in sharing knowledge, and that's what makes students not to like medicine or join a particular profession. So we need to share the knowledge, and someone love it and someone come to do it. This is my perspective about it.
Thank you very much.
I feel all the great things have been already said. So I will just reinforce 2 points. So first, community building, I just said, I think organizing, students can organize themselves and really actively seeking that proximity with communities that are suffering. I mean, I think really these 2 things, I think if students can do that, that will be a good way to further the cause and give us the insight we need to move this forward.
Thank you very much. Well, I think we started a little about 10 minutes off, so I think we have just like 9 minutes left. I have one final question for the group, which I think would be fairly quick to answer. So we've got reimagining social medicine. With that in mind, I would like to ask you that if you could think of one innovation in your institution that you represent that you would like to see used to sort of teach social medicine, can you think of one innovative idea that if cost was not an issue and there were no restraints, what would you like to see done?
I want to think by saying, let's not wait for social medicine idea to the graduate level. Let's start it at the foundation level of training so that people grow with it in their mind. If we are able to teach mathematics at foundation level of education, why not to bring the theory of social medicine at foundation of education so that everyone grows with it and is able to project it out? Because this is multidisciplinary. It is not one discipline. It's not a family physician. It's not a gynecologist. It's not a neurosurgeon. It is wholesome, holistic. So we need to approach it at all dimensions. Like we are saying, immunize a child, wash your hand clean. We talk about this language in social medicine right from foundation education. This is my thinking about it.
Great, thank you.
One word comes to my mind, empowerment. Empowerment in that, especially for post-colonial countries like Uganda, there is this idea I find in communities whereby I feel everything must be done for me. I'll wait until somebody comes to rescue me. And this is possible, this is not possible. Is it like what Sande says, I want to reach that level whereby someone feels I can think in a different way. I can innovate about my problem. I can, even as a practitioner, I can decide not to focus on the biologic with this particular patient, but can I innovate and can we start with the social approaches? Can we advise the patient if we can manage, if we can prioritize the social aspects together, So it is now, again, a paradigm shift. Yeah.
Thank you. Dr. Finnegan?
I think for me, it's about more, creating more rigorous, robust kind of space for critical self-reflection on privilege and power in the teaching of social medicine. And I think in particular, I think a couple of emotions come up when we talk about privilege and power. I think some of us who maybe have a lot of privilege, and we come to terms with that, we feel guilty. And I think some of us who maybe experience a lot of, we have less privileges, we experience sort of disadvantages, oppressions from the way society is. I think we may experience a lot of shame. And guilt and shame are powerful emotions, and I think we need to kind of create more space in our classrooms and in the pedagogy to reflect on those, because I don't think those alone are going to lead to social change. But I do think creating space to reflect on shame and guilt about the way the world is, about the inequality that exists, could be very helpful for moving us forward.
Thank you. Dr. Paul?
I don't know if that's an innovation, but I think it will be very useful if countries, so-called developing countries like Haiti, could have the kind of platform that is needed to develop robust research to understand the social forces that are causing inequality and at the end of the day, disease. I think it's pretty well documented in a lot of different countries, and I think there is an imbalance in the kind of evidence. So there is a lot of inference we are doing when we are doing social medicine in developing world, and a lot of that is based on literature that has been developed elsewhere. So I think if there was enough resources and we can correct that imbalance and that we could know more about the root cause of disease and not really guess. I mean, there is things that everyone knows and we kind of assume they are true, but I don't think there is enough rigor or enough resources to have the rigor to kind of move forward with social medicine in the developing world in the same way we are doing it elsewhere.
Thank you. And Dr. Thibault?
So I would emphasize teamwork. Teamwork in the learning and teamwork in the doing. And those teams can be made up broadly of health professionals, doctors, nurses, social workers working together, and non-health professionals bringing in the other sciences of sociology, anthropology. So this is a team approach, and that needs to be part of the language, part of the construction of it. Nobody owns it. It isn't owned by one profession. It does deal a little bit with the power issues within our professions. So there has to be a sense of equality in all of the participants in the process, a certain humility that all of us come incomplete to the process and need others to accomplish our goals. And that should be part of the learning process from the beginning and then part of the doing process.
Thank you so much. Well, it has been an absolute pleasure to share the stage with such people. Can we have a round of applause for all of them? And thank all of you. Thank you.
Wonderful. Thanks again to all of our amazing speakers this morning and our panelists, just who I think have raised a set of really challenging and inspiring questions for us to consider. Two themes I think that we heard resonating throughout the morning so far, this idea around honesty and dishonesty and also proximity. And one of the ways that I think we get to more honesty is through proximity. And our hope is that this afternoon after lunch, the breakout sessions that we have are a chance for us to get a little bit more proximal to the people who are really engaged in this work on a day-to-day basis and are really thinking about how do we do this in the clinic through narrative medicine? How do we use community health workers to really connect with communities? How do we use social movements and advocacy to work for health equity? How do we think about bridging the clinic and the community through using participatory action research and some other ways of engaging the community? And then what are sort of the transformative models of education? And we've heard a little bit about that this morning. So that's the idea with the breakouts after lunch. They are not here in this building. There's a map in your program. It's about a 10 or 15 minute walk to Moose Tower. And then they're all kind of within the same area. And then we're going to run them twice so folks can come to them twice. It'll be the exact same thing that happens twice. And we will still start those right at 1:30.
We'd like to just highlight the fact that we know many of you started your journey in learning about social medicine and some of the themes that were discussed this morning years ago. Some of you are just starting over the past couple of months. Some of you maybe are just starting that journey today. And we want to pay tribute to the fact that this takes time to understand these ideas. It takes time to understand these invisible forces that we're not taught to identify. And we really, one of our biggest aspirations for today is that this conference and these discussions and the amazing people that you're hearing from, the amazing organizations that you're hearing about are a part of your consciousness and self-awareness. So we, encourage you to continue to toil with that and to continue to learn and to continue to struggle in your mind with some of these very challenging concepts and very hard things to hear. We also want to just get a little bit of a pulse on the audience. Can you just raise your hand if you are a student? Fantastic. Thank you guys. Can you raise your hand if you are from Minneapolis? Amazing. Please raise your hand if you're from outside of the U.S. Not bad. And please raise your hand if you are a health professional. Sweet. Last but not least, please raise your hand if you are a doctor. Okay. We really want to note that, especially over the past 2 days and even today, a lot of the representation and leadership in social medicine is doctors. And many of our panelists and discussants this morning highlighted this point, that this cannot be a doctor-led movement. And even though we might be starting a little bit in that way for historical reasons and friendship reasons and partnership reasons, one of our visions and dreams and aspirations for this work as well is that this not continue to be a doctor-led movement. And we're going to continue to grapple with that for the rest of the day as well.
The other thing to mention now, it's lunch break. There are boxed lunches outside for everyone. We tried to, folks put in their dietary things that they wanted. Hopefully that is taken care of outside. And also just remind you that lunch is also part of the reason we decided to put some funding into having lunch is just in the spirit of community building and dialogue. And that's another common theme this morning. And John had a big stack of questions for the panelists, so we know there are lots of questions and conversations that are to be had, so we'd encourage you to do that during lunchtime.
Last, before we actually break and get to eat together, we want to highlight the point that a big part of the principles that guided our organization's SocialMed, Equal Health, Partners in Health, many, many others. A big part of the principles that guided our planning for today was that we know that there are many, many, many voices that are systematically excluded from this conversation and from the literature in the U.S. and from what's published in the U.S. and from the academic side of social medicine. And we worked very, very hard and very actively together as organizations to say that part of how we reimagine social medicine is that that cannot continue, and that this conference, which perhaps will continue for years, will be one of the ways we can fight that trend and the forces that created that trend, such that the voice is not always me or Mike or any of us who are from the US, but that the voice of social medicine really reflects the practice of social medicine that's happening all over the world every day. And that, as you might expect, takes time and planning and resources. And we really want to just also open up the opportunity that if you agree with that principle and you want to continue to support that principle, that changing, that silencing, and actually bringing the voices from all around the world here and bringing our voices standing in partnership to all of our partners around the world, we would be honored if you would continue to support the work that we're trying to do to change the conversation and to challenge the status quo. So with that, please feel free to use your QR coders, if you have them, to take a picture of this and contribute if you would like to, and enjoy your lunch. Thank you.
Thank you. This is a song written for a man of